Hi there, good evening. My name is Dr. Pavel Jankowski, and I'm a neurosurgeon at Hoag Memorial. My specialty is in spinal deformities in adults and children, and today I'll be talking to you about adult spinal deformity surgical planning and patient-specific planning, but primarily the first portion of this talk will be also looking at as far as describing adult spinal deformity and talking about treatments. So starting off here, let's get the groundwork laid out as far as some definitions. Adult spinal deformity can result in a deformity in the coronal plane, which is specified as the anterior posterior plane, or the sagittal plane, which is the lateral portion when you're looking at somebody standing. The deformity can arise from idiopathic scoliosis that has carried over from the patient's childhood years and then developed as they've gotten older, or it can be a de novo deformity that has progressed over the years due to degenerative methods and processes. Adult spinal deformity has a high prevalence in the elderly population, especially between the ages of 60 to 80 years of age. What we primarily see in the adult sphere as one ages is deformities that are apparent in the sagittal plane. And I'll show a picture here in a few slides demonstrating the two types of planes more specifically. A common feature of adult spinal deformity is pain, and it's not associated with any type of other deformity in the coronal plane. And furthermore, many of the patients who have this, when asked, they don't identify as having a type of a deformity. So here we have a picture of a patient from the age group between the 60 and 80 years of age with a sagittal plane deformity, and we can see here how her head is positioned anterior or forward in front of her pelvis, and if we were to draw a gravity line from her neck all the way down to the floor, it would be significantly in front of her pelvis. Here we have a standing x-ray image of somebody that has a coronal plane deformity. This is the more traditional scoliosis that we are used to hearing about. And here we see an example of a deformity that is primarily present in the thoracolumbar region of the spine. The reason that sagittal malalignment and sagittal plane deformity in adult spinal deformity patients is important is that in a study that was published by Glassman and his colleagues out of the Leatherman Institute in Louisville, Kentucky, it showed that as you increase the sagittal malalignment, you also increase the disability. So this graph here is showing us a direct correlation looking at the Oswestry Disability Index and the San Francisco 12 Disability Index, which are health quality outcome measures. The higher the ODI score, the greater the disability. The lower the SF-12 score, the greater the disability. And we can clearly see here that as that sagittal malalignment increases and we increase the distance of the head relative to the pelvis, we also increase our level of disability. We also know from studies that if one is able to improve the sagittal plane, this results in a significant improvement in the level of pain for the patient along with the quality of life. We have here a patient that underwent a previous spine surgery and then received a correction afterwards, and we can see here not only on the x-rays but also in real life standing images the correction in her posture. Ideal spinal alignment and the most ergonomic alignment that we can maintain throughout our lives is when there's a balance with the head positioned directly in line with the pelvis. So if you can imagine attaching a string from the side of your ear and letting it hang down, and if that string crosses in the middle of your pelvis, that means that there is a perfect alignment and that there is also the most least amount of energy required to maintain your upright posture. This is accomplished through a complex relationship between the physiological curvatures of the spine, the morphology of our pelvis, and the musculature of the spine system. Here we have the cone of economy. This was a concept that was developed by Dubuisset, who was a French spine surgeon, and this diagram dictates that the most ideal alignment, as mentioned before, is when the head is positioned directly over the pelvis. The further that the head deviates away from the pelvis towards the periphery of the cone, the greater the expenditure that is exerted on our bodies in order to maintain upright posture. And that expenditure obviously comes at a cost, which is pain. Increasing positive sagittal imbalance causes a position towards the periphery of the cone. Increased muscular effort and energy expenditure. This results, again, in pain, fatigue, and disability. If the body is shifted beyond the periphery of the cone, we have certain compensatory mechanisms that are then activated to maintain our balance. Gravity is always going to be pushing us forward, and we're always going to be resisting the effect of gravity. The way that we maintain our balance in this particular situation is through certain types of compensatory mechanisms. The first of which involves retroverting our pelvis. The second involves flexion of the knees, and then further down the line, extension of our ankles. We can see here in this diagram a linear progression of these type of compensatory mechanisms more clearly. On the far left, we see alignment that is ergonomic with minimal energy expenditure. As the spine begins to kyphose or deviate forward, we first see a pelvic retroversion compensatory mechanism take effect. After that fails, then we see a bending of the knees, and once that's overcome, we see a further progression of deformity. In this diagram again, we see a aligned spine, and as the spine begins to become out of alignment, we can see that the pelvis starts to change shape through the retroversion, and then as the spine begins to progress forward, we see the progression of deformity. The compensatory mechanisms don't come without a cost and a price. So the severity of the disability, as it increases, it also increases our compensatory mechanisms and vice versa. And the graph below, let me just go back. The graph below shows that as the degree of the compensatory mechanisms increases, so does our level of disability and decreased quality of life. This graph, as in the previous mentioned slide, shows the Oswestry Disability Index and also the SF-12. When these compensatory mechanisms fail and there's a progression of deformity, we need external factors to help maintain our posture. So one of these that is commonly seen is the use of an assisted walker device, a cane, or a crutch. All of this is to prevent us from falling to the ground. Now on to assessment and description of deformities. The way that we identify and delineate deformities most accurately is through radiographs. MRIs, CTs are used for a host of other diagnostic tools, but the best way to look at the spine and its alignment, along with describing the compensatory mechanisms, is through a 36-inch cassette film. Here we see that, and we are able to look at the patient in the coronal plane along with the sagittal plane. The hips and the knees are to be fully extended as much as the patient is able to perform. Elbows and wrists should be fully flexed. Hands should be placed ideally on the clavicles or across the chest. And there should be no external supports to help the patient stand upright. This slide shows some of the radiographic parameters that we are trying to establish. We're trying to identify the amount of thoracic kyphosis, the amount of thoracolumbar lordosis or kyphosis that's present, the lumbar lordosis towards the bottom of the curve. We are also looking at the global alignment. The sagittal vertical axis allows us to describe accurately with millimeters how far the head is positioned in relation to the pelvis. We are looking also at the sacral slope and the compensatory mechanism of pelvic tilt. The PI, which is known as the pelvic incidence, is our own each and individual, so to speak, fingerprint for our spine. We all have different pelvic incidences. It develops throughout our teenage years and then becomes fixed as we progress through adulthood with little change. Therefore, this is the constant that the other parameters are measured against and used to describe the level of deformity, the level of compensatory mechanisms, and also what needs to be performed in order to re-establish a normal ergonomic alignment. Some of the newer advances in imaging is the EOS system. Here we have a picture of an EOS Edge machine, which will be arriving at Hoag Newport shortly, towards the end of the year, which allows for patients to step into a room-like structure and with 10 cameras at different angles, allows for the patient to have a very accurate depiction of their spine with 1/10 the radiation dose of a traditional X-ray. And then also the radiology technicians can do other formatting in 3 dimensions to accurately depict the spine. Let's spend now a brief moment to talk about some of the classification algorithms that exist that have helped to identify the deformities, and also this serves as a tool for practitioners when talking amongst each other and at meetings to have a common language. So the most widely used and accepted adult deformity descriptor is the Schwab Scoliosis Research Society Adult Spinal Deformity Classification Scale. This identifies the type of curve types, where the primary deformity is, whether it's in the sagittal plane or the coronal plane, and then it also talks about the compensatory mechanisms that are in place. Those are listed as the sagittal modifiers. So you can see 3 of them here, and they are graded based on the level of compensatory mechanisms that are enacted. We also look at then, so to just briefly go through them, the pelvic incidence minus the lumbar lordosis, the global alignment, which is the sagittal vertical axis, and the pelvic tilt. This was the initial classification scale that was used and had been in place for well over a decade. Over the past 5 years, there was articles that started to be released after evaluating our patients, and these articles, such as this one here, which is shown, told us that not all patients need to be aligned the same way, and that age and that the patient's pelvic morphology played a key role into what their optimal alignment should be. Since that time, we now have age-adjusted goals for establishing where a patient should be aligned in the sagittal plane. We can see here a slide from the article that was mentioned previously here, showing 2 patients based on their age-adjusted alignment. And we can see on the right-hand side where a patient that, based on the original Schwab SRS classification scale, may have seemed to be in alignment, but actually has been overcorrected based on their age. The main thing to take away from this is the realization that people who are in the younger age group, from anywhere from 20 to 30 years, do not need to be walking or standing in the same type of posture as our population that's 60 to 80 years of age. Here we have another example of this. This is a table that I use in my practice that came out of research that I was part of, that breaks down the patient's pelvic incidence and also their thoracic, their T1 pelvic angle. And we can see here essentially that on the bottom right hand of the screen, if a patient has a certain pelvic morphology and is above the age of 65, they don't need to be aligned as straight as a person who has a pelvic morphology under 40 and is less than 45 years of age. Another key descriptor and a way to assess spinal deformities is through the global alignment and proportion score. This came out of research from the European Spine Deformity Group, and this paved the way for allowing us to measure certain parameters in order to help us guide if there would be a postoperative breakdown of hardware or a postoperative complication. Another tool that is widely used and accepted in describing spinal deformities is the Rousseli classification score. This breaks down curve types into 5 types, And the essence of this morphology is that everybody falls into one of these 5 curve types. These 5 curve types have a certain predilection for what type of spinal disease one will develop later on throughout life. And when trying to treat patients based on these curve types, the goal is to reestablish the original curve type. So let's talk now about assessment and how we evaluate patients with spinal deformities. The first and one of the most important steps is to get a good history. First is to identify if the primary symptom that the patient is experiencing is pain, how long this has been present for. Is it due because of previous surgeries? Is it due because of trauma? Does the patient have other medical comorbidities that could be contributing or complicate their management? The most common that we see in this population group is diabetes, tobacco use, obesity, osteoporosis, and cardiovascular disease. Also, establishing a reference point of activity level is important. How active has the person been leading up to this, and how has their activity level changed, especially in the past year? Next, as we talked about previously, is establishing radiographic parameters and measurements to find out the level of deformity along with the compensatory mechanisms that are in place. Aside from using the scoliosis imaging in the 36-inch films, we also use dynamic films to look at how mobile or immobile a curve type is. We look at MRI to evaluate the nerves and the other neurological structures. We look at the CTs to get an assessment of the level of arthritis and also to establish the level of osteopenia, osteoporosis, and then a bone density scan. As far as non-surgical treatment goes, not everybody who has a spinal deformity needs surgery. The most important treatment that one can call upon to help with this is physical activity. So this comes in the form of preoperative to back up, it comes in with rehabilitation through physical therapy, guided exercises. And these physical therapy exercises primarily are designed to help a patient with their core strength along with their lower extremity strength. Once physical therapy is not enough, then other conservative management can be applied, such as pain injections. These can range from steroid injections, facet block injections, or nerve ablation procedures. If those methods fail, then a discussion needs to be had about surgical treatment. Most importantly is to establish the goals of the surgery. And the first and foremost important goal of that is to restore the appropriate sagittal, if a coronal deformity is present, a coronal alignment as well. You see here on the slide listed some of the goals that we're trying to look at as deformity surgeons. And these here are broken down into numbers, but really what this is telling us is that we are trying to reposition the head over the pelvis according to the patient's age and their pelvic morphology. We also are trying to reduce the compensatory mechanisms that the patient will have to call upon, and we're trying to restore their normal curve type and achieve a global balance as defined by the GAP score. So this slide again breaks that down to what I just described. Some of the advances in surgery that have come about in the past decade involve primarily the preoperative planning. Prior to planning softwares and prior to planning for surgeries, deformity surgery involved long incisions, long operating times, and trying to recreate a sense of balance as best as possible. However, preparation and planning tools now allow for us to actually plan the stages of the surgery, exactly what needs to be accomplished in a surgery to restore the alignment and reduce compensatory mechanisms. We have also, in the past decade, seen the development and implementation in the clinical sphere of augmented reality and navigation technologies. Artificial intelligence system, along with predictive analytics, help to define where a patient needs to be aligned, and also what the non-fused or non-operated parts of the spine will behave after surgery. We have improved our real-time neurological monitoring. We have also seen tremendous advances in spinal implants, and also how we think about what a patient needs to do in order to prepare for such a surgery, some of which include nutrition, cardiac, and physical strengthening. So to describe some of these and then to jump into some cases, here we have a patient that that came to see me in clinic, and this is a preoperative planning tool that is called SurgiMap. We can see here the blue line as the ideal anatomical alignment that the patient should have based on his age and his pelvic morphology. The numbers that are to the right of the screen in the left-hand image show the patient's compensatory mechanisms that are present. So this patient, the reason you see this slide is this patient came already to me with a certain operative plan that he felt he needed. And by running through this plan with him through the planning software, I was able to explain to him that had the surgery been done according to what he thought was necessary, it would lead to an adverse outcome. And so we can see that the slide on the far right is the surgery that eventually the patient ended up having, which was able to achieve the desired outcome. The gap score here, which is used, also allows for us to place the patient's current anatomical parameters, and then the program calculates if a spine is in alignment or out of alignment. And then on the far right-hand screen shows us numbers to where the spine needs to be brought to in order to be in alignment. Augmented reality and navigation tools such as 7D, which we have here at Hoag and I use on all my cases, allows us to safely and accurately direct spinal implants, along with making as a preoperative planning tool and safely running through these type of procedures. We see here some intraoperative images that are made with the 7D navigation system, and you can see here how this is used in real time to help guide the implants. So other tools that we have at our also disposal now are augmented reality reformats that allow for us to view the spine and plan for where the surgery needs to take place, and also to look at exact anatomical parameters. Another tool that I have brought here to Hoag in the past year is through a company out of Europe that is called NEO, and this company here has developed a program that allows you to plan the ideal shape of a rod and the ideal alignment that one wants to align the patient in. You can see here a tablet that is used by the surgeon, which shows an augmented reality image of the rod, and on the right-hand screen shows a direct one-to-one correlation how the rod needs to be bent in order to achieve that alignment. Additional planning tools that are also used are looking at what the compensatory mechanisms of the non-operated regions of the spine will behave like, to assess the muscle strength that is present in the lower regions of the spine, also to evaluate the core strength throughout the hips and the legs, to determine the flexibility of the curve, and nutritional status, which goes many times underappreciated and unnoticed by practitioners. So let's go into this and run through some cases here. So in the first case here, this is a 77-year-old female with a rapid progression of curvature greater than 20 degrees in 1 year. When approached, when she sought help from her primary care provider, an outside hospital, she was referred for pain management. She was told that she was not a candidate for surgery and that the level of deformity was far too great. Subsequently, she required the use of a walker to help ambulate and maintain balance due to instability. We can see here her radiographs. So the patient has a severe coronal deformity along with a deformity in the sagittal plane that is present on the right. Her curvature measured greater than 70 degrees, and her compensatory mechanisms were completely exhausted, and she was falling over as a result. So in running through this, we identify first what type of curvature she is in order to restore that type of curvature, which was in this case a Russelli type 4. We have here some of the other numbers which essentially show the level of deformity that the patient had present. We can see here also towards the bottom that her gap score was a 13, which represents severe malalignment. So this is her gap score printout. And now we see here afterwards the correction that was needed in order to restore a harmonious alignment. She underwent a surgery with a fusion from T3 down to the pelvis. She also had accessory rods both on the right and the left to help further reduce the level of curvature over the coming months to years. From a curve of over 70 degrees, we were able to reduce her curve to under 10 degrees. In the sagittal plane, we were able to also achieve a harmonious alignment, as you can see here with the pre-op picture on the left and the post-op picture on the right. And afterwards, once her parameters were assessed again through the gap score, we have achieved a proportion spine. The next patient is a patient that had an iatrogenic-induced deformity, which is commonly seen as well. And this patient was a 73-year-old male with 3 prior surgeries, with a most recent surgery of L2 to the pelvis at an outside hospital. He had a past medical history of DISH, which is diffuse idiopathic skeletal hyperostosis, where a sheet of bone begins to develop in the anterior portion of the spine. He was complaining of significant neck pain and upper back pain. He was hyperextending his neck in order to maintain his gaze straight ahead and to maintain a level of balance. He had decreased sensation in the right foot and weakness from an injury prior. So again, we go through some of our parameters here that establish what type of curb type he is, the level of deformity that's present, along with the compensatory mechanisms, and also to plan what we need to achieve in order to restore that level of alignment. So here is this picture, and we can see here in the planning software, the blue line describes to us where his spine should be positioned. His gap score, which shows it's severely disproportioned spine, and the planning that was undertaken in order to map out his surgery and achieve the appropriate sagittal alignment. This patient underwent a fusion from T11 down to the pelvis with a pedicle subtraction osteotomy at the lumbar 4 region. A pedicle subtraction osteotomy is a wedge osteotomy where a triangular piece of the vertebra is cut out in order to mobilize the spine backwards. And the gap score afterwards, which shows a proportioned spine. The next patient was a 74-year-old female that was presenting with severe back pain, right leg pain, weakness, and sensory loss. She complained of her right ribs digging into her pelvis. She had failed extensive conservative treatment. Her past medical history was notable for prior orthopedic procedures, however otherwise unremarkable. On her physical exam, she had mild weakness in her right foot, decreased sensation. She walked with a bit of a limp and a forward-leaning posture. We can see here her images, which again show a deformity that is present in the sagittal plane on the left and a coronal deformity present on the right. We go through again the type of curve type, the level of deformity that's present along with the compensatory mechanisms that are in place, and the targets that need to be established to maintain her balance. We see here her preoperative sagittal plane film, where the blue line shows us where her spine should be aligned, and after the procedure that she underwent, that we were able to restore the appropriate sagittal alignment. In the next slide here, we see examples of the pre- and post-operative coronal plane, showing where on the left-hand side her head is positioned off to the side. If we were to draw a line from the center of her neck down through her pelvis, in the post-op setting we can see how that line now runs through the center of the sacrum where it's supposed to fall. We see here the changes that took place after the correction procedure and how we were able to realign her and bring her back into the appropriate target parameters. The fourth patient was a 73-year-old female with a progressive deformity, suffering from severe back pain, difficulty maintaining balance while standing and walking, and was undergoing progressive weakness in the legs. She had also exhausted all forms of conservative management. So again, once again, we go through the different types of parameters here, and the Rousseli type that she had, and the compensatory mechanisms that were in place. This patient had a 50.3 degree curve in the coronal plane, which we can see here. So we can see the curve, and also we see the sagittal plane deformity on the right. This patient underwent a T3 to the pelvis, anterior and posterior spinal fusion, which allowed us to realign her spine in the coronal plane and also achieve a more harmonious posture in the sagittal plane seen here. And this shows the changes and the restoration of the appropriate alignment after the surgery. We were able to reduce the lumbar curve from 50.3 to 9 degrees. Patient 5 here has a deformity again in the sagittal plane and in the coronal plane. What I tell my patients is that when looking at a scoliosis is typically considered as an anterior-posterior deformity, but what one has to remember is that scoliosis is a three-dimensional entity. If you were to take a piece of paper and look at it down the barrel and twist it, that's what's happening to your spine. So the deformity is being present in all three planes. And one deformity in the anterior-posterior plane will typically result in another deformity in the sagittal plane due to this twisting-like effect that happens. This patient here had a 53 degree curvature in her thoracic lumbar spine. We also here used bending films in order to determine the level of flexibility and rigidity that the curve had. This is important in order to establish for preoperative planning and which regions of the curve need to be fused. We see here a breakdown of the patient's deformity and other parameters as we've discussed previously. We see the patient's gap score here showing severe disproportion. The surgical plan in this case included an anterior procedure consisting of an anterior lumbar interbody fusion at 4.5 and 5.1, along with a lateral interbody at L2-3. The second stage consisted of a posterior spinal instrumented fusion from T8 down to the pelvis, along with osteotomies from T12 down to L5, and a sublaminar band to prevent for failure above the level and to accommodate for compensatory changes of the thoracic spine. The kickstand rod on the right was used to take out the residual deformity over the coming months to years. This is a 6-month post-op image which shows the correction and the improvement of the curve down from 53 degrees down to 14, and also a restoration of harmonious sagittal alignment on the right. This shows the pre- and post-operative coronal plane imaging, and this shows the pre- and post-operative sagittal plane imaging before and after the surgery. And we can see here from the initial gap score to the post-operative gap score showing appropriate alignment. That's it for today. We will be following up with another presentation later, and I'll take now time to field some questions. So the first question is, what lifestyle changes would you suggest to prevent a 19-degree curvature from getting worse? Also, is it possible to improve the curvature? So very good question, and one that I frequently encounter in my clinic. So first and foremost is to establish that sometimes I hear this amongst my patients and in other discussions that people hear that when they enter adulthood, curvature will stop. And I want to take this time to address that that is not correct. So we have good documentation in the spinal deformity literature to indicate that curve can progress anywhere from 1 to 3 degrees per year. Some of the things that one can do to prevent progression, especially when they have a small curve such as this, since 19 degrees is considered a small curve, is rehabilitation. So I mentioned this in one of my slides previously, is to be set up with a good rehab group, work on core strength, especially in the abdominal region and in the pelvis and in the legs. This will strengthen the muscles, which in turn attach to the facet joints and the rest of the spine, and will offload many of the forces on the discs, the joints, and other regions of the spine that eventually degenerate to make a curve grow larger. As far as improvement of the curvature, that is not possible. Once a curvature has set in, it's there, and people are keen to know if they can reverse this. Unfortunately, we don't have any clinically proven methods of reversing curvatures other than surgery. There has been claims by certain types of rehab methods, such as the Schwab method, which there is a facility here in Orange County that does this, that claims to be able to reverse curvatures. However, this is very highly debated in the deformity world. But they have shown some success with being able to arrest a curve if it is under a certain amount of degrees. Next question here. Is it metal hardware that is used for these surgeries? So the type of materials that are used nowadays in spinal deformity procedures primarily consist of titanium. Originally, when spinal hardware came to be used, it was stainless steel. However, after the inception of titanium, there was additional benefits from this metal that made stainless steel become obsolete. Some of the problems with stainless steel were that they showed an increased incidence of infections through the growth of biofilms. Also, certain people had adverse reactions to the metal. Titanium shows that it doesn't grow any type of biofilms. It also isn't caustic to the body at all. And when there is a type of a reaction, it's a case report basis and extremely rare. Some of the other materials that are used in addition to titanium are cobalt chrome. And also we have different types of plastics, such as PEEK, that can be used in the inner bodies. As implants continue to evolve, the search continues for materials that can accommodate to the body easier, and also that will decrease the amount of implant failures that can happen in these surgeries. Implant failure still is not uncommon and something that is a risk of these type of procedures. When a patient goes through a procedure, like patient 1, what will their post-surgery mobility be like? Great question. So one of the things I like to tell my patients, and actually I ask them, is tell me what can you do now? And typically the answer that I get is not much. So when the spine has undergone that significant amount of degeneration, you can't look at it like a normal spine. The mobility that a spine gets is through the soft ligamentous structures and also through the movement of the joints. As the degeneration sets in and severe arthritis takes hold, and there is also a disappearance of the discs in many times, the mobility that a normal spine would have and the degrees of freedom has changed. So a patient at that point can't do many of the things that they could do many years ago. And people will say that, well, I'm not 20 years old. But really what it is that the spine has degenerated to the point that it can't maintain that level of activity or degrees of freedom. So the mobility of a patient, such as the one presented in patient 1, actually is predicated based on what a person could do prior to surgery. Some people, when you ask them, for example, a simple test to do is when you try to touch the floor with your hands. Some patients will bend like a sheet of paper where they keep their legs straight and they don't rotate across their pelvis and they bend their backs downwards. Those type of patients are at significant risk for, after a surgery such as the one that I showed, will lose a lot of mobility. Patients, however, that can rotate across their hips to touch the floor will be able to maintain a fair amount of movement and flexibility afterwards. There is definitely no denying that a patient's mobility after a surgery such as the one shown in the first case will be different. However, though, the rehabilitation that comes on after a surgery such as this is incredibly important, because it teaches people how to utilize their pelvis and their lower core strength to maintain a level of flexibility and mobility. Can weightlifting help my treatment? So, if I'm understanding this question correctly, is weightlifting helpful in alleviating the progression of a spinal deformity and progression of degenerative disease? The answer to that is yes, that resistance training will help. However, it does also need to be coupled with increasing core strength. Core strength, unfortunately, it doesn't come into the conversation a lot of times and is neglected by many of us, including me. Several years ago, I actually got a personal trainer of my own to help with my core strength, and I was shocked to see how weak I was. So it's something that not everybody uses on an everyday basis, and when we go to a gym, it's not one of the first things that we actually look to exercise on a routine basis. Some common things in addition to working out at a gym on core strength is swimming and Pilates, which one can do on an everyday basis and is incredibly helpful in maintaining the vitality of your spine and your musculature, including with helping bone health. Next question is, I had a cotrell fusion, so that comes from one of the original spinal instrumentations that was used, cotrell Dubussé, when I was 17 years old. I do not have any problems now. Is there anything I should be aware of? I am 50 years old now and live a normal lifestyle. Also, so great question. So at that time, during the cotrell Dubussé times and along the Harrington rod days, is our understanding of spinal deformity, balance, was very different than it is from today. And for example, when discussing Harrington rods were used to stabilize a deformity in adolescents with idiopathic scoliosis and to alleviate and partially improve that coronal deformity. What we didn't know until many years later was that it was also creating a deformity in the sagittal plane through a straightening of the spine. As far as the cotrell Dubussé type of instrumentation, which is more closer to the instrumentation that we use nowadays, that's changed. We don't see as much of that type of deformity. And what I always tell patients also is that one has to treat the patient and not the imaging. Just because the deformity has present, just because somebody's been told they have a scoliosis, doesn't mean at all that they require surgery, and doesn't mean even that surgical indication is recommended in that. Again, the primary indications for surgery, going back to one of the slides that I went over earlier, is progression of pain that is not responsive to conservative management, along with a steady or fast progression of a curvature that makes a patient unstable when walking. So if you're doing fine and you've had this surgery, then there's no need to do anything at this point, and just continue to focus on taking care of your body and avoiding spine surgeons. Thank you very much.